Good morning, ladies and gentlemen. Thank you very much, Prof. And I would like to also rely on the existing protocol that has been established and just proceed with the key findings from our study. So we sought out to first quantify the economic and social costs that are associated with poor waste management and poor sanitation in Ghana. Now, before I get into that, it's important for us to understand where we are at the moment. So at the moment, for the year 2025, for example, we invested, when I say we, I mean Ghana, allocated a total of about 180 million Ghana cedis to waste management and sanitation. Now, these were shared obviously across the MMDAs in the country. Metropolitan areas were allocating on average 2 million Ghana cedis to waste management and sanitation. Municipal areas were doing on average 690 million Ghana cedis, and then districts were doing on average 307 million Ghana cedis. Now, these amounts that had been allocated translates into about 10 cedis per capita for the whole year in metropolitan areas, about 5 cedis per capita in municipal areas, and about 3 cedis 50 pesos per capita in the districts. Now, what did we do? We took 5 key disease conditions that are associated with poor sanitation and poor waste management. These are malaria, cholera, pneumonia, typhoid fever, and diarrhea. And then we sought out to look for a number of things. Number one, we looked at how many days are lost by people who have suffered from these disease conditions, what we call the lost days. Now, these are days lost because people do not go to work or they cannot go to school because they are suffering from these disease conditions. So we examined lost days. Then we examined mortality. How many deaths are recorded that are linked to these 5 disease conditions? Then we, of course, looked at the DALYs, which is disability adjusted life years. How many years have been lost due to premature deaths, people who have died prematurely? They did not attain our life expectancy age because they suffered any of these disease conditions. And then also we did look at the direct medical costs involved in treating episodes of any of these disease conditions. And then we also did the indirect costs or productivity losses that arise as a result of people suffering from these disease conditions. Now, when it comes to the direct medical costs, this is what we did. So we had data over a range of a lower bound to an upper bound of how much it costs to treat a single episode of, say, malaria, how much it costs to treat a single episode of cholera, pneumonia, typhoid fever, and diarrhea. Because it's over a range, we were working with, the midpoint of the range. We don't go to the extreme or extreme high or extreme low end. Now, we found that for malaria, for example, it costs 450 cedis to treat a single episode of malaria on average, 620 cedis for cholera, 1,848 cedis for pneumonia, 475 cedis for typhoid fever, and 55 cedis for diarrhea. And so for all the episodes of malaria, cholera, pneumonia, typhoid fever, and diarrhea that are recorded in a single year, we quantify how much is spent in direct medical costs. Now, these are costs that are borne by households and by the government, of course, because government have to make payments to the NHIS. Now, these costs came to a total of 5.6 billion Ghana cedis in a year. So these are direct costs associated with these disease conditions which are related to sanitation and poor waste management. On productivity losses or indirect costs, we use the human capital approach, where we estimate the value people bring on the table, okay, and therefore the productivity loss could be equated to the productivity or the value that is lost because these people were not at work or at school. Now, to examine the value people bring to the table, one way to do it is to look at what do they get at the end of the day when they come to the table. So that is wages and salaries. I have to say that for the purpose of this exercise, we relied on the national daily minimum wage, which is about 20 Ghana cedis. Now, you would all agree with me that there are many people who earn more than the national daily minimum wage, and therefore using the national daily minimum wage in this exercise means that this is a really, really conservative estimate that we have put out here, and the cost could way exceed that. Now, what we do is that we examine the length of days for each episode, length of days lost or length of hospital stays for each episode of each of these disease conditions. So, for example, if someone has malaria, they are likely to be out for between 1 to 5 days. Now, these are all epidemiological data that we have sourced and we are using for this analysis. And again, we go for the averages, the midpoint. Okay. So, for malaria, lost days per episode is 3 days. For cholera, 3.5 days. For pneumonia, 9 days. Typhoid fever, 4 days. Diarrhea, 4 days. What it means is that if someone is out or someone is sick, suffering from cholera, they are likely to be away from work for between 3 to 4 days. Now, for each of these days that we are losing their productivity, we have quantified it by looking at they earning the minimum wage of 20 cedis per day. And therefore, if they earn, say, 1,000 cedis or 2,000 cedis, it could even be more. Okay, all right. Now, for the indirect cost, the total for these 5 disease conditions came to 650 million Ghana cedis. So, in all, direct and indirect costs of suffering any of these 5 disease conditions came to 6.2 billion Ghana cedis. Now, other things that we lose, for example, mortality, about 107,000 people are dying because of these 5 disease conditions, and the DALIs is more than 3.8 million. So 3.8 million years are being lost, okay, by people who are suffering these conditions because they died prematurely or they spent time away by living with these conditions. And then, of course, the lost days, nearly 32 million lost days when we put together all the episodes that can be suffered by people. So that's the first part. That's our quantification of that. Number 2, we sought to look at the social and economic implications of poor waste management, or conversely, if we would invest more. 4 key findings came out. Number 1, many of our respondents we had metropolitan and municipal environmental health officers in there. We had operators in there. We had people who aboboya or informal service operators, and the people who patronize their activities, of course. Number 1, they largely agree that there is an adverse effect of poor waste management on public health. Number 2, they agree and acknowledge that poor waste management leads to absenteeism, skipping work, being late to work, and for those in the public and shared spaces, like the market centers, we were there, like the lorry stations, we were there in this research, they said they lose businesses, okay, during these times. Well, many of the informal operators, particularly or specifically aboboya operators, did not seem to quite agree or perceive that there are any health implications associated with the work they do in the manner that they do it. However, every one of them did believe that there are employment opportunities that could arise if we would invest more in sanitation and waste management. Thirdly, we sought to develop or do an investment prioritization framework. What should we prioritize, okay, in that sense? And we did this using 2 approaches. First of all, we had what we call the business as usual case. So this is where we don't change anything and we do what we are doing at the moment, i.e. we spend our 180 million Ghana cedis every year on sanitation. And then we looked at what we call the best case scenario, which I will explain in a bit. Now, what we did was to examine the potential gains in either scenario and then compare them. So in the first case, which is the business as usual scenario, the government of Ghana maintains its 180 million annual investment into sanitation and waste management. Now, because we are generating about 4.6 million tons of waste every year, this 180 million translates into a spending or an average spending of 38 cedis per ton of waste generated. Okay. Now, if we break that down, metropolitan areas are spending about 64 cedis per ton of waste, municipal areas about 40 cedis, and about 32 cedis in districts. Now, the other case is what we call the best case scenario. Now, what we did in the best case scenario is to let investments align with the average standards expected of lower middle income countries, which Ghana is. Again, these average standards of investment into waste management in lower middle income countries are over a range. Okay, so there's a lower bound and an upper bound. Again, sticking with being consistent with what we've done over the course of the study, we go for the midpoint. So we are not even going to the extremely high values, and obviously we are not staying with the too low values. Now, best case scenario or best case expectation on average for lower middle income countries is an investment of 1,519 Ghana cedis per ton of waste to manage a ton of waste in metropolitan areas. 957 Ghana cedis to manage a ton of waste in municipal areas, and 769 Ghana cedis to manage a ton of waste in districts. Now, if we average this at the national level, weight a few things, this comes to about 1,080 Ghana cedis at the national level as the best case scenario. This is how much we should be investing per ton of waste generated, as opposed to 38 cedis per ton of waste, which we are currently investing. I think that you can make the conclusion from here. Now, we proceeded to look at what is the returns to the investments that we are making in waste management and sanitation. What are we getting back? Again, we did this for the business as usual scenario, and then we did this for the best case scenario. Okay. Now, in the business as usual scenario, for every 1 cedi that we invest in waste management, the returns is about 180 Ghana cedis at the national level. Of course, the returns differ across areas, about 99 cedis for metropolitan areas, about 202 cedis for municipal areas, and about 290 cedis for districts. But then at the national level, that comes to 180 cedis. Now, in the best case scenario, if we invested 1,080 cedis per ton of waste generated, then the returns is going to rise to about 556 Ghana cedis nationally. Again, at the metro areas, there's about 390 cedis. At the municipal areas, there's about 444 cedis. And then at the district areas, about 590 cedis. So when we average that and do a little bit of weighting in there, that comes to about 556 Ghana cedis for every 1 cedi that we invest in waste management, if we did the best case scenario. If we maintain with the business as usual, we are only earning 180 cedis per cedi invested. Now, where are these gains coming from? The increase in the returns, where are the increases coming from? Now, the key drivers of the increases in the case of the best case scenario is reduction in sanitation-related morbidity. If we are able to invest as much as 1,080 cedis per ton of waste generated, we are almost wiping away sanitation-related disease conditions. That drops by more than 97% in our modeling and analysis. The attributable mortality also drops by about 81%, and then the DALYs also drop by nearly 90%. So these are the key drivers that are yielding the returns from every 1 cedi that we will invest in sanitation and waste management. Okay. So essentially, what we are saying is that in the business as usual scenario, yes, we are investing some money, all right, at the moment. That yields us returns of about 180 cedis. If we did what we should do and clear a lot of the waste that we generate, or perhaps nearly all the waste that we generate, then our benefits is going to rise to about 556 nationally. Now, the last thing I'll talk about before we make some conclusions and recommendations is that we also estimated what the total benefits per year is to the country under the 2 different scenarios. Certainly, as long as you are making some investment, there will be some returns. So certainly, even under the business as usual scenario, we have some returns. We are making some benefits. Okay, and we did our modeling for a period of 8 years, from 2025 to 2032, applied a discounting factor, and then we computed what the total benefits would be. And these are the benefits that are arising from the medical costs that we don't have to pay. These are the benefits that are arising from the productivity losses that don't happen. These are the benefits that are arising from all the things that I've already spoken about. Now, in 2025, the benefits that we are getting from in the business as usual scenario is we are making benefits of about 6.8 billion Ghana cedis. And this could rise to about 8 billion Ghana cedis by 2032 if the government of Ghana commits to 100% funding of the current waste budget. However, if we did the best case scenario, the multiplier effect is huge. The total benefits, if we had invested 1,080 cedis per ton of waste in 2025, the total benefits that would accrue to us would be about 58 billion Ghana cedis. And this could rise to about 67.2 billion Ghana cedis by 2032, which is what the last year that we modeled up to. So, in conclusion, I think that the results do show, without doubt, that Ghana spends relatively modest amounts in investing in sanitation and waste management compared to the economic and the economic losses, productivity losses, the costs involved when we look at it. Preventable diseases linked to poor waste management, the malaria, the cholera, the pneumonia, the typhoid fever, and the diarrhea, which we studied, are giving us close to 32 million lost days in a year. 177,000 deaths attributable to these 5 disease conditions in a year, and of course, 6.2 billion in losses, both direct and indirect losses. And our qualitative exercise on the field confirmed some of these things, or all of our findings. We find households and our respondents confirming that erratic waste collection, poor waste management, and so on contribute to sick days, it contributes to them missing work, or they go but they are not working, so presenteeism, absenteeism, loss of productivity, and so on. And so we have a number of recommendations, but I'll highlight just 3. I think the obvious recommendation then we want to make as a research team and as ESA is that there has to be substantial increment in investment in sanitation and waste management. But we want to immediately add that whenever we are making the case for the increment, we need to include the health co-benefits to make a justification for increased investment, rather than just look at what we are budgeting and thinking, okay, we don't have the waste, or as my senior colleague said, we are just dealing with a social issue. There are health co-benefits, and if you could quantify them correctly, then we could make a case for the increased investment in sanitation and waste management. We want to recommend a focus on high-risk areas like urban slums, the flood-prone areas, to reduce issues of pneumonia, cholera, and so on, and the mortality associated with them. And also, we want to recommend support for MMDAs to prioritize the hotspots in peri-urban areas within their jurisdictions. The last recommendation we want to make is that we want to recommend support to strengthen the capacity of MMDAs to improve or enhance their data systems and their planning and their budgeting. We would love to see MMDA's budget for waste and sanitation, having done some of the work that we have done, putting in some numbers. What are the health returns? What are we losing if we do not invest? And then that kind of exercise would then inform the budgeting for sanitation and waste management. And we think that some support given to strengthen this capacity of MMDAs to do this would be very crucial, and it would go a long way to improve the situation in Ghana. So thank you very much for your attention.